Hi guys, I'm Dr. Sneha and today we have Dr. Rohan who is a surgery resident in Kolkata and we are going to have a short session on peripheral arterial disease.
So thank you, Sneha. Okay. So we
Mm.
will begin with the topic. The topic for today is peripheral arterial disease. And so let's begin with the introduction. It is also called as the peripheral arterial occlusive disease or the peripheral vascular disease. So basically it refers to the obstruction or any deterioration in the arteries which are supplying other than the heart and the brain. Generally we prefer in the legs and the hands. So yeah, most commonly it affects the legs, but other arteries are also involved in this case. So this is a basically classification of PVD. We have divided into three types: arterial, mixed, and venous. So in arterial, we have the occlusive and the functional. In occlusive, again, we divide into two, that is acute ischemia and chronic ischemia. So what is the most common cause of acute ischemia is the emboli, whereas in chronic ischemia, we have the atherosclerosis or any microangiopathy. Then functional, we have the Raynaud's disease, which it is due to basically most commonly due to smoking, which will cause vasoconstriction and cause, as it is written, vasospastis. Then we have the venous, we have the thrombosis and the varicose vein. In thrombosis, we can have a superficial the venous system and a deep venous system. And in myths, we will have both arterial venous fistula. So today we will only be discussing on the arterial system, not on the venous part. So yeah, the arterial stenosis and the occlusion, as I said, the most common we have the atherosclerosis or the thromboembolic disease. And other causes are result of a trauma, particularly in the younger adults. And there's a severity of the symptoms related to the size of the vessel and not to the stage. Most commonly acute and chronic, what we have already said. So in acute, we have suddenly, it will be there suddenly, and chronic, it is gradual process with a progressive narrowing of the artery over time. So in chronic, what is the important thing is there is a formation of collaterals. So in the body, we have collaterals which gets formed, gives a chronic condition which will provide the blood supply to that area. There is also alternative pathway until there is a critical stenosis or it has been fully occluded. And in acute cases, we don't have any time to have collaterals only. Then moving on to acute. So most common is the emboli, thrombi, and trauma. So what is the meaning of emboli and thrombi? If you know, what is the difference actually?
Thrombi is basically the clot which forms at the particular site and emboli is dislodged from a different site.
Yeah. So basically, after generally thrombi is the accumulation of the lipid or whatsoever cholesterol in the fatty patients, and if it is dislodges, it forms an emboli in the body. That is the emboli. So what are the most common sites? We have the limbs, brain. Brain, the most common artery involved is the middle cerebral artery. And there is something called as amaurosis fugax. It is seen in case of eye. There is a temporary loss of vision due to the acute obstruction of the central retinal artery in the retina. We also have gut and kidney involvement if there is a occlusion. So in gut and kidney, it will be most commonly acute abdomen we will see because of the obstruction and which will form again gangrene and all that changes goes toward the sepsis. So yeah, as the image we have there is the emboli which has been seen in the what is the artery? Can you name the artery? Basically artery in
Oh, I'm
which
not sure.
it is a common iliac artery divided into again internal and the abdominal
External,
aorta
okay.
and abdominal. This one down part is the internal. This is the external iliac. Another common iliac artery from the aorta.
Okay.
Then we have the embolus. We have the types of embolus, thromboembolic, that is formed because of a thrombus. Then we have the due to fibrillation, MI or any endocarditis, basically because of any inflammation in the left atrium, which will form again an embolus. Then aneurysm. So what is aneurysm? Any idea? What is aneurysm? Or
Basically, enlargement that occurs in the vessel wall due to weakness of the vessel wall, like
yeah,
abnormal enlargement.
yeah. So as per the definition, it is more than 50% of the normal. It is called as aneurysm. Then again, atherosclerotic plaque we have due to the cholesterol deposits, fat, air embolism most common. Then we have the infective, parasitic, and malignant. So in the image, you can see that there was a thrombus formation, and then it got dislodged, and it is now emboli. Then what are clinical features in case of acute? It's a sudden, and there's a severe onset of pain, and we have the 5 P's here: pain, pallor, paralysis, pulselessness, and paresthesia, or numbness, what it is. Then the limb will be cold, tender, and swollen, and the toe cannot be moved. If occlusion is more than 6 hours, we will call it as irreversible, and there is a presence of a line of demarcation will be there. So in case of chronic and acute, the major difference what we will see here is a sudden onset, and in that there is a chronic, but you can see pain will be there, pallor will be there, paresthesia won't be there basically. Paresthesia and paralysis won't be there in chronic cases, whereas in acute cases we have paralysis and paresthesia also. Moving ahead. So what is the investigation? There is something called as ALI, that is acute limb ischemia. So yeah, in that the time is everything, because if we waste time, it will cause to a irreversible damage. So in worst, it can progress to critical limb ischemia. And what is the choice of investigation? We have done a Doppler study. So again, we will divide it into three: viable, threatened, and irreversible. So have you ever seen a Doppler study? Intensive you might have seen in
Yeah,
surgery.
I have seen. Yeah.
So
Surgery
what do you
testing is not yet done, but I've seen.
Doppler in gynae also we have Doppler, and
Yeah.
probe Doppler you have. Okay, what is the immediate management in this case? It is an emergency, and if there is a patient having a history of cardiac disease with acute limb ischemic all that features, what I have said, immediate management has to be done. And what is the choice? First of all, we give a heparin IV, that is 5,000 units of heparin IV. So what is heparin? As is, it is anticoagulant to prevent further basically extension of thrombi or maintain the patency of the vessel. We give a heparin in that case, 5,000 unit, and then we give analgesic for pain. Then surgical management, as it's an emergency, we can go for an embolectomy. So what do we do? You can see in the image itself, there is something called a Fogarty balloon catheter will be introduced in the artery, and with that the clot is dislodged basically, and it is removed from the artery. So it is done under the local anesthesia, and it is a procedure of choice. You can see the image where the clot is removed. Then it is the intra-arterial thrombolysis can be done. You can give a septokinase, urokinase, tissue plasmin as an activator. These are basically all that platelet inhibitors, so that platelet doesn't go there and doesn't cause any further formation of clot. Then again, it is injected into a clot via the catheter, and it is achieved within 24 hours. Regular angiogram has to be done after the removal of the clot to check for the patency of the vessels. Again, what are the contraindications? We have the recent stroke, bleeding diathesis, pregnancy, and age greater than 80. So, do you know why? Any idea why we don't give stroke or any bleeding disorders?
Uh, it is like bleeding disorders are not, sir. Others are hypercoagulable states, so it is contraindicated.
Basically, streptokinase, it will not cause platelet aggregation. So, in bleeding disorders, also there is no platelet aggregation, it will lead to more and more bleeding. Stroke is the same thing. Bleeding will continue basically in all these cases.
Okay.
And after managing, we have to check for the cause of it and then proceed. Then moving on to the chronic cases. So as I said earlier, also most common cause is the atherosclerosis. It is due to a deposition of cholesterol and lipids within the vessels. And again, it will lead to a narrowing of the artery, which will decrease the blood supply to that area. Other causes are we have the blood vessel inflammations, injury to the limbs, unusual anatomy or ligaments or muscles, which will be covering that, and the radiation exposure. Then these are the two artery. First, you can see the normal artery, and then again you can see the atherosclerotic artery. In atherosclerotic artery, you can see the plaque formation, which will again cause narrowing. Nothing much to tell. So yeah, what is the risk factor? Smoking. Why? Why smoking is the risk factor? Any idea? Most common risk factor for atherosclerosis. Why people having
No, I'm not
basically
sure.
it has nicotine in it is. So what does nicotine does? It increases the inflammation of the arterial wall. Again, first is the inflammation, other is the it causes more and more lipid. It attracts the lipid to form and stay there. The first is the another one more reason is vasoconstriction. So nicotine can cause inflammation, vasoconstriction as well as the lipid deposition, enhancing the lipid deposition. Then again we have some diabetes, which will cause an endothelial and the smooth muscle dysfunction will be there in the arteries. CKD, hypertension, hyperlipidemia, and hypercoagulable states are the other risk factors for this. And these are other risk factors, not that common, but yeah, CRP, family history, age. In increasing age, what happens? The elasticity of the artery wall, it will become less elastic, thin walled, and becomes calcified. Again, there will be increasing the peripheral vascular resistance in high age groups, which will again lead to increased BP. And if there is increased BP, there are high chances of the vessel wall damage. And again, vessel wall damage will lead to inflammation. And again, all that process inflammation will cause deposition, all that thing, platelet deposition. Then we have hyperhomocystinemia, hyperuricemia, obesity, sedentary lifestyle, and stress is one more risk factor. Then yeah, these are all the arteries. A common iliac artery, consider anatomy in this case. Common iliac artery divided into two, internal and external iliac. And again, the external iliac will form the common femoral artery. It will divide it into two, superficial and deep. And again, the deep femoral artery will go form the popliteal artery. Then again, popliteal artery divides into three. In the below the knee, we have the anterior tibial, posterior tibial, and the peroneal arteries. So these are the most of the arteries involved below the in the leg. So in patients who have diabetes, it is most common we will see the peripheral artery disease below the knee, and whereas in non-diabetic patient we have seen it is seen in most common in the femoral and the popliteal area, not below the knee. Then again the pathophysiology. So we have all these mechanisms. First is atherosclerosis. Again, it will cause lipid accumulation and all that. Again, it will cause narrowing of the lumen, reduction in the vascular blood flow, and ischemia and PAD. Then we can have a vascular remodeling, thickening of the vascular wall, that calcification can occur. In case of smoking and all that, it happens. Then endothelial dysfunction, decrease in NO. So basically, what does NO? NO is a nitric oxide. So what does the deficiency of NO do in the blood vessel? Any idea about it? What does the deficiency of NO or decrease in NO? Basically, decrease in NO in the vessel, it will cause vasoconstriction. So again, decrease in the blood flow and ischemia and all that. Then we have thrombosis, which will again lead to blockage. So this is all the pathophysiology of the PAD. So yeah, these are the stages basically. So what happens first is the hemodynamics changes occurs, then microvascular adaptations will occur, then at last tissue will remodel. So these are all the stages. So what will you see again? A decreased ankle pressure, then angiogenesis, arteriogenesis, endothelial dysfunction, and muscle fiber damage at last. So at first your body will try to compensate, then rest pain will happen, chronic non-healing ulcer will be there, gangrene will form, and at last we have to amputate the leg. So these are all the stages. In compensation, basically the collateral will form. That's why. So these are all the staging of the normal artery to a atherosclerotic artery and PAD. Then this is the most common in the exams also you have I think read Berger's disease, also called as thromboangiitis obliterans. So in this there is acute inflammation and occlusion of the arteries and the veins both due to thrombosis. And it has a very strong association with the cigarette smoking. So whenever you go to surgery ward, you can see a patient with burgers from outside only. When you enter, you can see a patient with burgers. Why? How? The patient has a very anxious look and he is in very severe pain. And the body language only you can tell that he's having a burger disease because his legs will be lying down from the bed. He won't be able to sleep. Basically, he will be sitting or he will hang his leg so that the pain reduces. and he won't be able to sleep in the night also because of that pain. So yeah, it commonly occurs in male 20 to 40 years, and upper arteries are involved, but generally we don't see the upper artery involvement. Usually lower leg, toes, and feet. So yeah, what are the clinical features? We have a term called as claudication, intermittent claudications. So what happens in this? There is a cramp-like pain which we feel in the muscles, reliably on walking, or it is not present on taking the first step. After walking only it starts basically, and it relieves on taking the rest in standing or sitting position, usually within 5 minutes. It relieves. So yeah, this is the boys classification of claudication. You have to grade that patient whenever you see the patient. You have to grade 1, 2, 3, and 4. So in grade 1, what happens? The patient complains of a pain after walking, and you have to measure a distance basically. It is called as the claudication distance. So if the patient continues to walk, so yeah, basically what they are telling is, suppose the patient is there, he starts walking, he has a pain, but after continuation of that walking, he will reduce the pain. Why? Because there will be increased blood flow to the muscles and the collaterals will open, and all that metabolites, because of the anaerobic metabolism and all that, it will release from the collaterals, again decreasing the pain. So it is called as pain subsides in grade 1. But in grade 2, what happens? Pain will still persist, but on walking, the patient can walk with effort. In grade 3, we have the patient has to take rest to relieve the pain, and whereas in grade 4, it is the last stage, rest pain. So, any idea why the patient has pain? Why the patient with
There
the,
is ischemia to the muscles, so because
okay,
of that.
muscle involvement, then why? What will
No,
happen? Suppose the ischemia is there, gangrene is there. So, in a patient with gangrene, do you see pain?
no. Here nerve involvement will be there,
Yeah,
so
yeah, yeah, yeah. Basically, in this burger disease, nerve involvement is there. Because of that, pain will increase, and the grade 4 is the rest pain because of the whole involvement of the nerve. So that is the rest pain. These are others physical findings you can see in a patient. We have the coldness in lower leg or foot, especially when compared to the other side. Really, coldness will be there, numbness or tingling will be there, again due to nerve ischemia. Neuropathy is present, there will be shooting, burning pain, sores on the toes, feet or leg that won't heal, change in color, hair loss, slower hair growth, and loss of pressure and deep pain sensation will be there. Again, slower growth of toenails, shiny skin, all this because of there's less supply to the area. Then no or very weak pulse and erectile dysfunction will be there in male. In male. Then yeah, you can see the picture. We have this is a finding you have to see in the world. First is elevation pallor and then dependent rubor and what is called as sunset foot sign. So you have to tell the patient to elevate the leg above the bed basically. What will happen? You will see the elevation of pallor. Why pallor? Any idea? Why pallor will be seen in
decreased
this?
blood circulation to the lower limbs.
Yeah, the blood will flow from the lower to the upper limb, basically upper area. And independent, the all the blood will rush over to the legs. So you see a sunset foot sign in this case. So that's why the patient keep the legs hanging down, so that the blood will go to that area because of gravity. So yeah, rest pain, it is a very last stage. If it progresses, pain may even occur at rest and or even on lying down position. So it aggravates on limb elevation more often at night. Why? Because there is a drop in cardiac output. Decreased cardiac output will lead to decreased blood supply to that area. So that's why he won't be able to sleep at night. The intense enough to disturb sleep and hanging legs over the edge of the bed or walking out may temporarily relieve the pain. Then this is the later stage. We have a late sign that is critical limb ischemia, CLI. So what happens in this? There will be a rest pain which requires analgesic greater than 2 weeks. Ulcer will be there, gangrene will be there, and systolic pressure of the limb less than 50 mm of edge. These are the features of CLI. Management will be here, but you have to differentiate between the CLI and normal stage. Again, there are two classifications. We have the Fontaine and Rutherford classification. Both are similar, but in Rutherford, we have additional two things. We have the minor and the major tissue loss. Again, as I can say, it is asymptomatic, mild, moderate, severe, ischemic, pain, minor and major tissue loss in the other foot, and in Fontaine we have ulceration or gangrene. So yeah, what's Raynaud phenomenon? Have you seen this? Raynaud's
No, I have not seen it, but
in generally
I've heard
don't
of it.
see heard of. Basically, vasospasm will be there. That there will be intermittent episodes in the small arteries or the arteries of the left and right arm. Vasospasm, which will again lead to change in the skin color and the temperature. Generally, unilateral affects one or two fingers only, and it may occur after any trauma, neurogenic lesion, occlusive arterial disease, connective tissue disorders. And again, as I said, decreased blood flow to the fingers, again because of vasoconstriction, leads to pallor, that is blanching. Then yeah, we have to physically examine to look for the, as I said, all the signs we have already discussed. And then we check for the blood flow in the leg. How do we check? By checking for the pulses. All the pulses you have to check. Femoral, we cannot check for iliac, but yeah, femoral we have to check. Popliteal we have to check, and arterial, tibial artery we have to check. Then there is segmental blood pressure. We have to measure the actual limb pressure of the both upper limb and lower limb. We have to check and measure both of them. So we have the ankle below knee and mid thigh. Yeah, condition you have to see. Yeah, shiny, taut, absence of hair growth, ulceration, necrotic tissues, extremely cold to touch. And we have the gradients of the pulse. We have 0 is absent, 1 plus is weak and 3D pulse, normal is 2 plus, and 3 plus is full and bounding. So yeah, you can see this capillary refill time will be normal is less than 3 seconds, but in this case you can find more than 10 seconds also, capillary refill of the nail bed. And loss of muscle or tone or weakness. So how do you check for capillary refill of nail bed? Well, how do you check for capillary refill? Any idea?
Press the particular area and look for the refill time.
Yeah. So normally it's 3 seconds. If it is more than 3 seconds, you can tell the blood supply is lacking in that area. So yeah, we can divide it in all that parts. We can have aortoiliac, iliac, femoropopliteal, distal obstruction we can see. So yeah, what happens is wherever there is a claudication, below that claudication point, you will feel you won't be able to feel the pulse in that area. Suppose in the above we have the aortoiliac. So in that claudication will be there in both the buttocks, thigh and calves. Then in this the most common is the calf muscle involvement. That is the femoral artery is most common involved in the lower limb. So as I have written already 70% we have the femoral artery, we have the unilateral claudication in the calf and pulse palpable and absent with absent distal pulses. So basically if we have the femoral artery involvement, the distal part won't have the pulse and claudication will happen to the distal part only. So aortoiliac, as I said, 30%. There is something called as Lerich syndrome. It is seen what happens in this, all that will be there, pain will be there, then erectile dysfunction will be there, and claudication, as I said, absent femoral and distal pulses will be there. Again, iliac, we have the unilateral claudication in the thigh and calf, and in the ankle, we have the ankle pulses will be absent, claudication in the calf muscle will be there. So what are the complications? Ulcerations will be there with slow healing because there is no blood supply. It will be painful and most commonly around the malleoli because the less supply, gangrene, and at last we have a sepsis. What are diagnostic tests? In the ward, we have to go for an ankle brachial index. Have you ever heard for it? What is ankle brachial index?
Yeah, the BP is measured at the ankle and the brachial artery, and then
Which BP?
the
SBP
range
or
of
DBP? Diastolic or systolic? So yeah, we measure the
not
systolic basically. Systolic, we measure the
systolic.
systolic BP. So these are diagnostic tests. We have the ankle brachial, Doppler, duplex, treadmill, angio, and blood test. So ankle brachial tests you can use by a handheld Doppler, or you can just measure by the sphygmomanometer. So it compares the blood pressure in the ankle as well as in the arm. So normally you have to remember is 0.9 to 1.4. So yeah, in this image you can see 0.9 to 1.4 is normal. Greater than 1.4 is non-compressible, and 0.4 to 0.9 is mild to moderate. Less than 0.4 is severe. Severe, or you can say PAD. So where do you find greater than 0.4? That is a non-compressible. In case of what happens? In case of diabetes mellitus, you can see a false elevated ABI. Why? Due to calcification, and non-compressive arteries will be present. So most common in diabetes, you see a higher, which will mimic like, but it won't be PAD. False elevated ABI will be there. So yeah, if it is less than 0.4 to 0.9, it is compensated, and less than 0.4, it is PAD confirmed. So yeah, as you can see here, it in sphygmomanometer you can see, or Doppler you can check for this. So yeah, Doppler ultrasound you check for blood flow, site of the stenosis, systolic pressure of the small arteries, and ABPI. You have to check. So the image you can see the transducer is there. You might have used this. Then this other figure, this is a normal artery, and you can see there is a calcified plaque in the artery. And so yeah, what is the image? This is a Doppler image, and this is a duplex image. So what is the difference between duplex and Doppler? In Doppler, we can check for the stenosis or the site of stenosis. But in duplex, what we can see, stenosis will be there, and turbulence of the, and as well as the velocity of the flow and the direction of the flow can be seen. All the 4 or 5 parameters we can see in this case. And it's a combination of Doppler study and the beam mode USG. So in this, it can be seen, but in Doppler only you can check for the ABP and all that, as a stenosis area. Treadmill test is done in case of early stages to check for the severity after the patient is walking in the treadmill. It will show the patient while any walking there is a PAD or not. So you can go for a ABI test before and after the treadmill test also. Then angiography, and this you might have seen or might have heard. It's an invasive procedure. It is indicated when intervention is required, and we use a Schrödinger technique, and femoral artery is preferred in this case. So what we do in this case, we put a angiography, we put a probe inside it, and we remove the clot, or we remove the stenosis area. So advantages: visualize the artery, site of occlusion, and the collateral can also be seen in this case. Disadvantage is that as it's a invasive procedure, there will be bleeding, hematoma, thrombosis, embolism can occur, arterial dissection or false aneurysm can be seen. So you go to that area and just remove the clot or remove the thrombus. So yeah, these are the two images. If you are doing in CT, it's a CT angiography. If you are using an MRI, it's an MRI angiography. Both in you, especially you put a dye, and that's why you can see the images. You put a dye and then you insert the probe. So the management risk factor you have to modify, as tell the patient to stop smoking, drug therapy, exercise therapy, nutrition therapy, and the care of the leg with CLI, critical leg, as I said, and minimally invasive procedures and surgical therapy can be given. So drug, yeah, these are all the controversial. Basically, pentoxifylline and silostazol can be given. It decreases the blood viscosity as it is written, but actually speaking, it won't affect that much to the patient. We can try it out. Basically, on trial basis, we can give. And the dose is 400 mg BD we give. It improves the circulation as said. And silostazol, it inhibits the platelet aggregation. 100 mg BD we give. Analgesic for pain management. Yeah. But yeah, we have to give low dose aspirin or clopidogrel. Any of the 75 mg per day, we have to give any of the above. So why? It's basically to prevent further formation, further thrombus formation, or further any formation, we have to give aspirin or clopidogrel. Then antihypertensive, anti-diabetes as per the comorbidities. Statins also we have to give for lipid, decrease in the lipid level in the blood. Antibiotic if required, if the patient is in gangrene or super added any infection is there, then only antibiotic has to be given. Then first we'll go for minimally invasive procedure, that is the PTA, that is a percutaneous transluminal angioplasty. Again, same balloon catheter has to be inserted via the femoral artery in this case, under the fluoroscopic guidance, and it is only for less than 5 centimeter segments, short segment we use. Whereas more than 5 centimeter segment, you have to put a stent and then come back. We cannot just expand and come back. So more than 5, as you can see in the image, we have a stent. Okay, so more than 5 centimeters. So yeah, then we have the transluminal stenting more than 5 centimeter. If there is a PTA failure, then also you can put it. So in the image on the left side, you can see before the pre-PTA and after post stenting, how the blood flow has increased in that area. And you can see a metallic stent on the right side. Then we can go for again minimally invasive surgeries like embolectomy, removal of the blood clot. When the large arteries are obstructed, you can go for embolectomy. Then atherectomy, that is a removal of the segment, or removal of the plaque, that is atherectomy. Then cryoplasty can also be done, combination of both PT and cold therapy. Cryoplasty is because we give a very low temperature to that area to dissolve, basically, dissolve the clot or dissolve the thrombus. Then surgical, if there is a severe symptoms are there, angioplasty has been failed or not possible, we can go for that. So you might have heard about bypass surgeries for heart, coronary artery bypass, CABG might have heard. Same thing applies to here. We put a saphenous, again saphenous vein we put is a bypass graft, natural. And if it is a saphenous or the arm vein graft we have, if it is a very long segment involved, we have to go for a synthetic, that is a Dacron or PTFE. And you can also go for an end arterectomy, lumbar symparectomy. What is lumbar symparectomy? Basically, you are going there giving chemical agent to destroy the nerve so that pain doesn't occur. This is a basically palliative treatment, you can say. And amputation is for the very last stage. If there is nothing gangrenous changes or the gangrene is present, you have to amputate. So yeah, this is the bypass. You can see the image of the saphenous vein is there. This is bypassing the already artery which is being present. So yeah, synthetic we have a Teflon for long bypass surgery, so that's axillary femoral bypass. This is the end arterectomy. You open the artery and remove the plaque, as you can see in the image. So again, this is also the same thing. End arterectomy has been, we are going there. This is the common iliac, which will again divide. We are going there, opening, and again, first the clamping the artery so that the blood doesn't come, and then again removing the plaque and suturing it. This is the other method, that is a patch graft angioplasty. The same thing as in arterectomy, what we are doing. We remove the plaque in this case, but we take a patch from other areas of the body or patch from other artery, patch from other part, we go, patch from other saphenous vein also we go and attach it. Why give a patch? So that the widen the lumen, so that lumen is widened, so that in future the problem doesn't occur. Then, yeah, as I said, in this we put a chemical agent and to block the pain. We are going to the ganglion nerves or the, you can say, the sympathetic chain, and we are just putting a chemical so that it destroys the nerve, blocks the nerve. Then yeah, this is the last option. We have the amputation. The amputation, what we prefer, generally what we prefer is below knee amputation. Why? Any idea? Why below knee amputation are preferred? Ortho questions might have been over.
It's over,
Just
but
guess it out.
I don't know.
So yeah, below knee amputation, why? After we have to rehabilitate the patient. So in case of prosthetic or a prosthetic leg, what we give to the patient, below knee amputation, there is a stump, or the stump will be there so that you can insert it for the prosthetic leg, artificial leg, what will be there. That's why we prefer it. So yeah, we have the different types you can see. Below the knee, that is a transtibial. Below that, it is a foot amputation. You can just knee joint, you can just disarticulate. Hip joint, you can disarticulate. And above knee, that is a transfemoral. So why do we amputate? If it is very much extensive, osteomyelitis will be there, gangrene will be there, and all the major arteries are involved. Then in this, the surgical goal is to remove at least the amount of tissue possible to create a stump adequate for fitting the prosthesis, as I said. So yeah, choice is above, and we have the above and below knee operation. Below knee amputation, why we do? We want to preserve the, basically if the patient want to walk again, we go for a below knee amputation. It preserves the knee joint and best chance for walking again. If the patient doesn't want to walk, the very age-old patient, he is not able to walk, so we can go for a above knee amputation. The advantage of above knee, it is more likely to heal faster than the below knee. Then how much stump should be there? At least 8 centimeters. Preferably 10 to 12 centimeters of the stump. That is a below knee stump should be present to have a prosthetic. And then at last we can have something called as distal and transmetatarsal amputation. That is below all that small vessel disease. Distal part can be amputated. So this was the thing. So yeah, thank you. So yeah, we end the session and moving on. If you have any questions further or anything,
No, I don't have any questions, sir. And it was a really informative and insightful session. Thank you for the session.
thank you.